So if it's very plethoric, I know that, together with other signs of RV dysfunction, there is likely RV dysfunction, and I have to treat the patient as such, and I will avoid volume. If my IVC is super collapsed, sometimes if it's very collapsed, I can't even find it. Then I know a collapsed IVC amongst all the experts that I talk to, like really, really small, almost not visible, that is bleeding and severe hypovolemia until ruled out otherwise. And to give volume there will likely not cause harm. But you see how careful I am to kind of give you that recommendation. But most patients are just in the middle where you don't know. And there are other assessments like the pulse pressure variation, like assessing stroke volume variation, like I showed you earlier through the PA. If there's a big variation in the right setting, that's more sensitive in terms of deciding if I want to give volume or not. I hope that's a short answer. There's a lot more to say about this. But I do think in general, the IVC variation, even with positive, and it's only valid, I want to highlight the IVC variation in diameter is only valid in patients who are intubated, ventilated, tidal volume of 8 cc's per kilogram or greater. They don't have any sinus arrhythmia. They don't have any arrhythmia at all. And they cannot have a very stiff lung. A compliance less than 30 centimeters per water column makes this test inaccurate. So you can see there's so many things, especially in ARDS patients, that already throw this method out the window. So if you use it, like I said, use the extremes, blown big, there's likely some RV problem and for sure not hypovolemia. Collapse, almost not visible, there is hypovolemia until proven otherwise.
Thank you, Dr. Panzer. Does it mean, Dr. Panzer, that you're willing to have another webinar and talk about the IVC?
Volume responsiveness, I'd be happy to. That's my special.
Yeah. Good. Thank you very much. Okay, there's a question here because I think you are involved in a lot of the treatment of COVID-19 patients in New York. The question is, what is the protocol of a COVID-19 patient who is in a prone position for treatment interpretation? So what is their protocol for a COVID patient in New York, in Colombia?
So yeah, I mean, there's a whole protocol. I'm not even sure if it's shared or not. I can certainly inquire to kind of share the protocol. It involves a lot of training. It's a dedicated team that does this because in these patients, the process of proning can be very dangerous by itself because you can imagine that a lot of pulmonary pressures, chest pressures change. There's a risk of pulling lines, disconnections, all that stuff. So it's a very highly specialized team who does that. The protocol, roughly, we see a rapidly worsening course that did not respond to paralysis. That's when we consider patients. Typically, when they're already on high FiO2s and very high PEEP, we do not do proning again. There is a window before you maxed out your ventilator therapy, but you see the course of the patient is rapidly escalating where you can do this. So you need to have enough cardiac reserve, so you need to make sure your patient is not in cardiogenic shock, that it can take it because it will change the preload conditions of the heart. And if you have a weak heart that's just kind of hanging on a thin thread, you're probably going to cause more trouble than benefit. And you have to make sure you're not already maxed out on a FiO2 100%, PEEP 15. So you need to make that decision just a little bit before, and you need to have a highly specialized team. In our case, it's a team from the medical ICU that is doing that. We in the surgical ICU, we have not had a lot of experience with it because we have a lot of abdominal surgery patients, so they're by definition excluded from proning. So there are a lot of limitations from proning as well, especially when it comes to surgery.
Okay, thank you very much, Dr. Pans. Miki, do we still have time?
Yeah. So it's almost the time to end now. So,
Okay.
yeah.
Yeah. But there are a lot of questions, and maybe the speakers can just leave their email to you, and they will be asking the attendees to send their queries to the respective emails. Will it be all right? Yeah.
Yeah.
Okay. So,
Sure.
okay. Thank you very much. It was
Thank you
really
very much.
it was really a great evening. Very
Thank you.
fruitful, enriching. We gained knowledge, wisdom, and knowledge from our experts and esteemed speakers. So, in behalf of the Philippine Society of Anesthesiologists, I would like to thank our doctors for attending this PSA Wisonic Dandelion College webinar. Now, as we come to a close, we in the PSA and Wisonic hope that we have given you a clear perspective of what lung ultrasonography is all about and the various clinical manifestations of COVID-19 patients using lung ultrasonography as well as cardiac ultrasonography. So I would like to express my appreciation, our appreciation actually, to our speakers. They're very good, Dr. Pen Cano and Dr. Oliver Panzer, for sharing their time, knowledge, experience, and expertise. I was looking at the chat box and they were saying, congratulations, nice webinar, and I couldn't agree more. And thank you for all the attendees for spending your early evening with us. Stay safe, and good night. Thank you very much.
Dr. Valera,
Thank you very much.
for being
It
our
was a
moderator.
pleasure.
It's our honor for the president of the society to be the moderator.
Good. Yeah.
Thank you.
Oliver.
Actually, I already answered some of the questions privately a while ago. So I started to answer some of them. So to not pile up, because I was seeing there were a lot of questions coming in. So I already started answering a few of them a while ago. While Oliver.
Tried a few as well.
Okay.
Hey,
Oliver.
Thank you.
Thank you
very much.
You'll be expecting a lot of invitations as soon as times get better. Expect some invitations from the Philippines. Yeah. Okay. Thank you very much.
Thank you, Oliver. Hope to see you again
Thank you
soon.
so much.
Yeah. See you soon.
Thank
Okay.
you.
Thank you, Mickey.
Thank you,
Thank you,
Dr.
Joseph.
Oliver.
Yeah.
Doc
Thanks,
Valera.
Mickey.
Thank you, Dr.
Thanks,
Acano.
Yes.
Bye, Mickey. Thank you.
And to the attendees, thank you for attending.